My topic for today is anesthesia for non-obstetric surgery during pregnancy. My goal is to preserve maternal safety, to maintain pregnant state, and to achieve the best fetal outcome. Incidence rate is 0.2 to 2%. Indication of the surgery directly related to pregnancy, that is cervical cerclage, indirectly related to pregnancy, that is ovarian cystectomy, unrelated to gestation, that is in case of acute abdomen cholecystectomy and appendicectomy. In case of trauma, visceral injury, hemorrhage, and vascular accident. Before that, we need to consider the maternal physiological changes. In short, I will go. In cardiovascular changes, system, physiological changes, cardiac output increases up to 50%, increase in the uterine perfusion to 10% of cardiac output, decrease in the systemic vascular resistance, and decrease in the peripheral vascular resistance leads to the hypotension, which is very common under regional anesthesia. Aortic cable compression starts from the 13 weeks of gestation, which leads to the supine hypotension syndrome, which requires left lateral tilt of the uterus of 15 degrees. In respiratory system, increase in the minute ventilation leads to the faster inhalation induction. Alveolar concentration of inhaled anesthetic is achieved rapidly. Decrease in the expiratory reserve volume, decrease in the respiratory volume, and decrease in the functional residual capacity. Increased oxygen consumption and upward displacement of diaphragm leads to the potential for the hypoxemia in supine and Trendelenburg position. Mucosal edema leads to the difficulty in laryngoscopy, intubation, and bleeding during attempt. In CNS, increased epidural vein engagements leads to the bloody tap, which is very common. Decrease in the epidural space volume, more extensive to the local anesthetic spread, and increase in the sensitivity to opioids and sedatives, which requires reduced local anesthetic requirement in pregnancy. In hematological, increase in the red blood cell volume by 30% and increase in the plasma volume by 50% leads to the dilution of anemia. Increase in the coagulation factors leads to the thromboembolic complication, which requires DVT prophylaxis. In GIT, increase in the intragastric pressure and decrease in the bariatric pressure requires aspiration risk in the pregnancy, which further requires anti-acid prophylaxis and rapid sequence induction after 18 weeks of gestation. In renal system, increase in the renal plasma flow and increase in the GFR leads to the normal urea creatinine, which may mask the impaired renal function. In hepatic and biliary system, acute cholecystitis is common due to the incomplete gallbladder emptying, and plasma cholesterase activity decreases to 25 to 30%, which starts from 10 weeks of gestation up to 6 weeks of postpartum. According to the American College of Obstetrician and Gynecologist Committee, regardless of the trimester, pregnant patients should not be denied for the medically necessary non-obstetric surgery. Maternal concern with non-obstetric surgery, which leads to the infection, re-exploration, respiratory complication. With pregnancy, it leads to the venous thromboembolism, aspiration pneumonitis, preterm delivery, risk of PPH in case prophylactic use. Rapid sequence induction and intubation with effective required pressure should be preceded by meticulous pre-oxygenation of 100% oxygen for 5 minutes. Ephedrine and phenylephrine are safe drugs for the maternal hypotension. Light plane of anesthesia leads to the increase in the catecholamine, which further leads to the impaired uteroplacental perfusion. Positive pressure ventilation should be used with the care, and tidal CO2 close monitoring should be done and maintained within limits. Fetal concern, which leads to the miscarriage of 10.5% in the first trimester, which is maximum 7 days after surgery. Small for gestational age. Preterm labor. Second trimester, risk is 16%. Third trimester, risk is 82%. In preterm delivery, risk is 16%. Teratogenicity to non-anesthetic medication. Neurodevelopmental changes. Maternal factor that leads to the fetal compromises. In this, transient fall in oxygen is well tolerated by fetus due to the high oxygen affinity, but prolonged hypoxia or hypercapnia leads to the uteroplacental vasoconstriction, which further leads to the decrease in the perfusion, leading to the fetal acidosis and may cause death. Hypocapnia leads to the decrease in the uterine blood flow and decrease in the oxygen delivery. Positive pressure ventilation leads to the hypocapnia and increase in intrathoracic pressure, which further leads to the decrease in the venous return and decrease in the uterine blood flow. Uterine hypotonia leads to the increase in the uterine vascular resistance, which causes decrease in the uterine blood flow. Risk of preterm labor is due to the surgery, uterine manipulation, and or due to the underlying condition that is sepsis. Lowest risk is in the second trimester. Prophylactic tocolytics may be used in third trimester for lower abdominal and major pelvic surgery. Teratogenicity, which as category A, there is no fetal risk in the control study. Category B, no risk to human fetus despite of the possible animal risk, or no risk in the animal studies, but human studies lacking. In category C, human risk cannot be ruled out. Animal studies may or may not show risk. In category D, evidence of risk to the human fetus and X is a contraindicating in pregnancy. Intermediate halothane, isoflurane, bupivacaine, opioids, and neuromuscular blocking agent comes in category C. Ketamine, lignocaine, propofol, ropivacaine, etc. comes in category B. Benzodiazepine also comes in category B, which leads to the cleft lip and cleft palate if used in the first trimester. Nitrous oxide should be better avoided in first trimester because it leads to the it inhibits DNA production, myelin deposition, methylation, and folate process. If used, pre-treatment with the folic acid should be done. Paracetamol comes in category B. It crosses placenta. It's safe for short-term use. Brufen, diclofenac, if used in third trimester, can cause the premature constriction of the ductus arteriosus. Morphine, codeine, and tramadol comes in category C. High doses and chronic maternal use can lead to the neonatal respiratory depression and withdrawal symptoms. Now, key principle of the anesthetic management. Maintain maternal physiological condition, maintain uteroplacental blood flow and oxygenation, avoid unwanted drugs and effects on the fetus, avoid oxytocin drugs, stimulating the myometrium, avoid awareness during general anesthesia, use regional anesthesia wherever possible. In preoperative evaluation, detailed medical and obstetric history should be done. Physical examination in that airway assessment and screening for the venous thromboembolism should be done. Lab investigation as per the medical condition. VT prophylaxis should be initiated. Written informed valid consent and counseling for the risk of preterm labor, fetal loss, and cesarean delivery should be done. Reassurance should also be given. In preoperative preparation and medication, NPO guidelines should be checked. Aspiration prophylaxis in that injection ranitidine 50 mg IV 30 minutes prior to surgery, injection metoclopramide 10 mg 30 minutes prior to surgery from 16 weeks of gestation, antibiotic prophylaxis and thromboprophylaxis in form of mechanical or pharmacological can be done. Left uterine tilt of uterus of 15 degrees after 16 weeks of gestation is required. Pre and post-operative ultrasonography and fetal heart rate monitoring from 18 to 22 weeks and fetal heart rate variability for more than 25 weeks should be done. Obstetric and neonatal facilities for the cesarean delivery should be there. And in case steroid for the lung maturity can be given if required, and tociloscis can be given if required. We should avoid hypoxia, hypercapnia, hypocapnia, hypotension, metabolic acidosis, hypothermia. Monitors ECG, pulse oximetry, non-invasive blood pressure, temperature, capnography, urine output should be monitored. In case of fetal monitoring, documented fetal heart rate pre and post-operatively should be done. Monitoring uterine contraction, external tocodynamometer can be used. Induction. We should always prepare for the difficult airway cut. Pre-oxygenation with 100% oxygen for 5 minutes or 8 vital capacity of oxygen can be taken by the patient. Rapid sequence induction for pregnancy more than 80 weeks. Injection ketamine, thiopentone, propofol may be used. Succinylcholine may be used to ensure the muscle paralysis. Maintenance with the inhalational and non-depolarizing muscle relaxant. Small size ET tube should be used. There is no evidence of teratogenicity of any volatile anesthetic, but use lowest effective concentration for short time. Titrated fentanyl boluses may be used. Tocolysis intraoperatively should never be used, but when indicated, we can use injection magnesium sulfate IV 2 to 4 gram over 20 minutes, then 1 to 2 gram per hour infusion. Intraoperatively, fetal well-being is best monitored by the maternal hemodynamic parameter. Maternal BP is the most important determinant for the uteroplacental perfusion. Phenylephrine and ephedrine are safest For the hypotension, ventilation is adjusted to maintain the normal physiological alkalosis. EtCO2 should be maintained within 28 to 32 millimeter of mercury. For extubation, reversal agent should be given slowly to avoid acute increase in the acetylcholine, which can lead to the uterine contraction. Patient should be extubated when she is fully awake. For post-op analgesia, regional nerve plexus block can be given. Opioids can be given if needed, and paracetamol for mild to moderate pain at any stage of pregnancy can be given. Avoid NSAID for more than 32 weeks because it leads to the premature closure of the ductal fibrosis. For decision in pregnant patient in elective surgery like burn contracture relief, it should be delayed till postpartum. For essential surgery like acute cholecystitis and large ovarian cyst, if greater than minimum risk with mother to surgery, we can go in for first trimester. If no minimal increase risk to the mother, we can consider delaying to second and third trimester. In case of emergency surgery, proceed to the optimal anesthetic for mother modified by consideration of for maternal physiological changes and fetal well-being, consult perinatologist and obstetrician, and intraoperative and postoperative fetal heart rate and uterine contraction monitoring should be done. In case of laparoscopic surgery, advantages are early ambulation, lesser bleeding, lesser manipulation of uterus, better visualization due to optical magnification, early return to GI function, reduce operative time. According to the Society of American Gastrointestinal and Endoscopic Surgery, timing of surgery can be performed safely during any trimester of pregnancy. But in limitation, in first trimester, risk of teratogenicity is there and 12% risk of miscarriage is there. In third trimester, there is a 30% risk of preterm labor and gravid uterus can prevent proper visualization of surgical field. Surgery has been successfully performed up to 34 weeks. In second trimester, there is a 0% miscarriage rate, 8% preterm delivery, and there is no risk of teratogenicity. Gravid uterus do not cause obstruction. Safest trimester to perform surgery, ideally done at less than 23 weeks of gestation. There is a modification of surgical technique by Society of American Gastrointestinal Endoscopic Surgery 2017 guidelines, trocar placement. All the patients undergoing laparoscopy are at risk of trocar injury. Hessens and Veress needle can be used safely. Gravid uterus causes difficult trocar insertion, increased risk of bowel perforation, uterine perforation, and preterm labor. Port is placed at least 6 centimeters above the uterine fundus. Alternative technique, that is gasless laparoscopy, can be used. Use of abdominal wall lifting device. Optical trocar, which allows visualization at the time of the trocar insertion. Intra-abdominal pressure should be between 8 to 12 millimeter of mercury. Do not exceed at 15 millimeter of mercury. Anesthetic consideration, gradual change of the position of the patient should be done in left lateral decubitus position. Intraoperative EtCO2 monitoring is essential. Mechanical DVT prophylaxis should be done. NGT, nasogastric tube is inserted to prevent perforation and aspiration. Effect of pneumoperitoneum, decreased blood flow to the uterus due to the decrease in the venous return, difficulty with the ventilation due to the increase in the intra-abdominal pressure and decrease in the FRC, fetal hypercarbia and acidosis due to the CO2 insufflation. In case of appendicitis, regional anesthesia is the technique of choice. We should do for prevention of the supine hypotension syndrome. We should always preload the patient with a crystalloid 10 to 12 ml per kg and maintenance of the fetal oxygenation. Exit procedure. It is an ex utero intrapartum treatment, operation on placental support. It is a method of delivering utilizing placental support while surgery is performed to secure the fetal airway. GA is the preferred choice. For tocolysis, IV NTG 0.5 to 1.5 mg per kg per minute can be used for uterine relaxation. Fetal analgesia should be ensured. Uteroplacental flow should be maintained. In case of trauma, it is the most common cause of non-obstetric cause of maternal death in US is trauma only. Gestation age is important for evaluation. In first trimester, fetus is protected by the bony pelvis and damage is unlikely. But in second trimester, uterus is exposed, IVC compression is there, compromising the perfusion and resuscitation. Blunt trauma can lead to the fetal demise, fetal injury, placental abruption, uterine rupture. For evaluation, fetal heart rate monitoring, ultrasonography, CT or and if required, exploratory laparotomy can be done. Key points to note that we should always avoid and minimize aortic cable compression. Perform surgery in second trimester wherever possible. Avoid elective surgery until after delivery. Regional anesthesia is always preferred over general anesthesia wherever required. Maintain normal maternal physiology. Maintain uteroplacental perfusion. Avoid fetal asphyxia. Avoid unwanted drug effects on fetus. And there is no anesthetic agent has been shown to be teratogenic in clinical use. Thank you, sir.
Excellent. Excellent. Very good.
Very nice, sir. Very nice, sir. Yes, sir. Very nice.
Very nice.
Thank you, sir.
And, I think my headphone is losing its charge. It's giving me warning. Two important points all of you have to remember that incidental surgery during pregnancy. One, we want to avoid preterm labor or miscarriage. Second, we want to avoid teratogenicity. So you have to classify the whole thing into first trimester surgery, second trimester, third trimester. So first trimester, if you have to do a surgery, for example, if the lady develops an acute appendicitis and it is the threat of it bursting, just because she is in the first trimester, you can't refuse it. So as she rightly said, the American College of Obstetrics and Gynecology said there is no reason for refusing a surgery which has to be imminently done in a pregnant woman. So you have to inform them and get their consent that there may be some changes happening because we have to save the life of the mother. So that comes as a priority. So the main point is the ideal time for any incidental surgery, if at all it is to be done, is second trimester, which is the safest. And she mentioned about laparoscopy, but there are other indications also. For example, a CNS brain tumor, which is increasing, which has been diagnosed pre-pregnant state, and mother becomes pregnant, and it is going to give problem in the second or third trimester. Even neurosurgeries have been performed. Similarly, patients who have had a cardiac problem, who require a cardiac surgery, a mitral valve replacement, they have undergone surgery in the third trimester, which is combined along with the delivery. That is, cesarean is done and then immediately followed by the also done. So that option is also there. So I'll try to quickly show a presentation on all these things before my